Really sure where to go with this, so we'll see where this goes. Um, but the idea is, how does it occur? Some concepts: should it be treated? Can it be treated? And how and when should it be treated? As Dr. Mercer pointed out, a lot of these do show up a little later than you would hope. And first off, does it exist? This paper looked at the potential prevalence of undiagnosed scaphoid nonunions and found that there are not a whole lot of these out there. Probably most of these are presenting with some initial problems and pain. This was also looked at as far as bone grafting. We've been talking about this for the past 20 years of my practice, but really not a new concept. There's a paper put out by Adams and Leonard dating back to 1928 describing management of these injuries with bone grafting. So some tips, I think the first is imaging. Of course, get them. We all should have a high index of suspicion for fractures. This can't be repeated enough that the fracture doesn't often show up on day one. It takes sometimes several days, a week or two, for there to be demineralization at the fracture line. So it's worthwhile to repeat wrist x-rays, particularly with an ulnar deviation view, which then brings the scaphoid on access. Bone scans have fallen out a little bit of favor for those that have ever had one. It involves an IV and dye and this and that. CT scan, a lot of radiation, and MRI now is very easy to get, very accurate, as you can see on these slides. This is sort of the CT scan. And the same concept is if you're ordering an MRI, be polite and tell the patient to be polite about getting an MRI in the plane of the scaphoid. So that just means when they meet their radiology tech, they sort of have to be firm but kind and said, my doctor really wants to get scaphoid views or I'll have to come back. And that's very important. As we heard from the last talk, know your anatomy. This will probably be the theme of the morning. Very, very important. And once you know your anatomy, I think really you can manage all of these problems this morning. But with regards to the scaphoid, we have to realize that the blood supply comes in sort of retrograde, which is unusual, right? The distal radius, all the blood flow is coming straight from the heart at a arterial gradient. Blood supply to the scaphoid comes in at this venous gradient. And then you can see if there's a fracture proximal to where the blood supply enters, those vascular channels in the bone are disrupted. So the proximal portion of the scaphoid, which is covered in nice glistening articular cartilage, does not get proper blood flow and thus has a difficult time to heal. What fractures are at risk? Sometimes waist fractures, but those generally will heal pretty well. Weber and Gelman showed that displacement matters. So the greater the displacement, of course, the higher the likelihood of nonunion, again, because of that vascularity problem and fracture displacement. And then last but not least is this inadequate treatment. So unfortunately, that patient who had a wrist sprain and then didn't do anything for 3 months finally shows up with problems. And this is sort of the fractures at risk. You can see the dysvascularity patterns. Delayed union can occur. You can see these even with immobilization. It's again hard to predict which fracture is going to heal, which fracture is not going to heal. And then we have to realize that if we do nothing, which is not necessarily the wrong answer, the patient just needs to be aware that they will likely have to have treatment, 15, 20, 25 years down the road with these various techniques. And there is not enough time to debate vascular versus non-vascular, whether to take medial femoral condyle or just do straight away a salvage procedure. This is sort of one concept just to think about. Here's your scaphoid fracture. And then we've, again, reiterated that this will have a high incidence of wrist arthrosis, and this was looked at in this paper. Really don't know necessarily the timing of this. It could be 2 years, 5 years, or longer. Here's another paper, again, demonstrating that left untreated, these injuries will lead to problems with the wrist. And again, they'll eventually lead to this snack presentation, busy slide, and we'll skip past that. Tip 4 is they can be treated. Roos is the classic article with talking about bone grafting and stable fixation. with good healing rates. Here's another paper demonstrating the healing rates of 95% with the deformity being corrected. They did use iliac crest and rigid internal fixation. So I think those are the takeaway points. If you learn nothing else from this talk, is again, proper carpentry, as we just heard with the distal radius, is the key. And that can obviously just be the theme for this morning. Tip number 5 is how and when. Residents and fellows always ask, what's the exposure? So for me, going volar is helpful if it's a waist fracture or the rare distal third scaphoid non-union. I go dorsally if it's a proximal pole non-union. Just visualization's better. It's very hard to see the distal scaphoid if you're going dorsally. The other tips and tricks is obviously you have to remove all the fibrous material. We'll hear later with nerves, if you leave scar, then the body just can't heal through scar. Liberal use of bone graft, I think, is key, whether it's from the distal radius, olecranon, iliac crest, which I've gotten away from. And Scott Wolf and others have taught us that the real key to this is solid, stable carpentry. There used to be the theme that you just had to put that screw center down the scaphoid when I was in training, and now there's a lot more evidence to suggest that you want to have your screw fixation perpendicular to the fracture, similar to our other fractures that are out there. And again, you can use 1 screw or 2 screws if necessary. There's also little plates and screws that are out there that we can look at in the lab. Of course, you want to do this before degenerative changes exist. The odds of this healing get worse and worse. So if you have a scaphoid non-union that's out there 2 years, I would talk to the patient, lay a little bit of crepe. I'm not saying it's not worth trying, particularly in a younger person, but the odds of success get worse after 2 years and certainly after 5. We're trying to preserve the scaphoid for matters of this talk. Headless screw fixation in my practice has been fantastic. I started my training with non-cannulated headless screws using the little jig. For those of us that have used it know that what a challenge that was. There's 17 different scaphoid screws on the market. They all kind of work very similar, causing compression at the fracture site, which stimulates bone healing. Authors have talked about the arthroscopic reduction, which you can kind of see here, which in theory then causes a little bit less disruption of the blood vessels around the scaphoid and perhaps allows the scaphoid to heal a little bit nicer. Some tip number 7 is why non-vascular. It's just a simpler procedure. You don't have to worry about tearing the blood vessel pedicle. You don't have to worry about finding the blood vessel pedicle. And you can concentrate on that reduction and carpentry. So here you see that Cohen and Jupiter published a paper with non-vascular repairs that all their patients had a united scaphoid. So what if you want to go volar? Can you do a vascularized graft? Yes. Again, this has been published by Judette and Roy Camille in '65, again in 1987. And you can see this is sort of the concept. Seth Dodd down in Miami has really done a lot of good work on that recently, where you can see your radial artery here in green. And then this just gets blown up here, and you can see how this vessel comes across. And you can take a volar distal radius with a little bit of pronator in this vessel, and that'll elevate quite nicely and mobile to the scaphoid. And here you see how it follows that anatomy. And this is just your standard volar exposure. I won't go into this too long, but I would reiterate that Dr. Mercer was brilliant with the exposure. This is trauma. This is not doing a little knee replacement. You don't have to make a 1 centimeter incision. The patient wants their scaphoid to heal. They don't care how long their skin incision is. Skin heals side to side, right? So get that exposure. I think that's worth reemphasizing. And this is kind of some schematics of how that blood vessel would be in. And you just have to take your time, like every flap, elevate this nicely without disrupting the pedicle, keeping the periosteum attached to the distal radius graft. And that comes up like that, and you can transition it and then hold it with your fixation of choice. And so vascular bone grafting was looked at in Journal of Hand Surgery, the British edition, with good results. You can see, of course, like every paper that's published, they all did well. More papers again. So there's literature out there to suggest vascularized and non-vascularized that both do well. So I think we can have this discussion over lunch and have some fun debate. And here's another paper talking about that volar repair with the little plate and screws, which is kind of nice. You're there volarly anyway. The little plate will help keep that bone graft in place, which is always the struggle if you're using screws or K-wires. So in summary, you can use the volar side of the distal radius for graft if you need to. I think it's a little bit simpler than doing that 1-2 Zeidenberg graft, which really is a big hit. Avoids the extra complexities of other grafts. And again, really the key is just making sure that you have reduction and stabilization. Confirming healing, again, the simplest thing is the patient feels good, there's no tenderness, you have disappearance of the fracture line on x-ray, bridging bony trabecular next to your screws if you're using screws. And I think I have a low threshold, particularly in the athletes, of getting a CT scan to really confirm motion before you let them get back to high-level athletics.